depending on where you're joining us from. And thank you very much for being with us on this press briefing of the Africa CDC. And we are coming to you from the headquarters of the African Union in Addis Ababa in Ethiopia. Now, as usual, we have Dr. John with us, and he will be talking to us about the current state of the COVID-19 pandemic in Africa. He will also be discussing the status of implementation of the Joint Continental Strategy for Africa for COVID-19, as well as touch on the topical issue at the moment, and that is of Africa's response activities and the rollout of vaccines of COVID-19 across the 55 member states of the African Union. Now, we are also expecting to be joined by Mr. Strive Masiyiwa, and Mr. Masiyiwa is the African Union Special Envoy on COVID-19, and he is also the coordinator of the Africa Vaccine Acquisition Task Team, abbreviated as AVAT. So we might also have Mr. Masiyiwa joining us online to brief us on the work that is ongoing under AVAT. But for now, let me hand over to Dr. John Nkengasong, who is the director of the Africa CDC, for his usual Thursday morning brief. Dr. John, good morning, and you have the floor.
Yes, I had a press conference. Hold on, let me go in.
Good morning, Dr. John.
Yeah, thank you. Thank you so much, Wayne, and a very good morning to all of you from the headquarters of the African Union, specifically from the Africa CDC. As Wayne mentioned, we are really honored today to be joined by Mr. Strive Masiyiwa, who is the AU Special Envoy for COVID and also a coordinator for the African Vaccine Acquisition Task Team. He has some very interesting and important updates to share with you on this platform today with respect to progress that we have made as a continent to continue to look for vaccines, which will obviously be a game changer for fight against COVID-19. As of today, July the 1st, 2001, 9 a.m. East African time, a total of 5.5 million COVID-19 cases have been reported across the continent. And this accounts for 3% of total cases reported globally. The total recoveries stand at 4.8 million people. That is also representing 88% of the total number of cases that have been reported positive and that have recovered. Unfortunately, over 142,000 Africans have died from these infections since the start of it, and that represents a case fatality ratio of 2.6%. Overall, 5 countries are contributing 64% of all cases across the continent. They include South Africa with 36% of all the cases, Morocco 10%, Tunisia 8%, Egypt and Ethiopia 5% both. 4 countries, Egypt, Sahrawi Republic, Somalia, and Sudan, are reporting a case fatality rate of higher than 5%. With respect to the variants, 32 countries or 58% of our member states are reporting the Alpha variant. The Alpha variant is the variant that was initially reported in the United Kingdom. And since our last briefing, 2 additional member states, Mozambique and Zambia, are reporting this new variant. 53% of our member states, or 29 countries, are now reporting the Beta variant, which was originally reported or identified in South Africa. 13 countries, or 24% of our member states, are reporting the Beta variant, a variant that was originally reported or identified in India. So let's look at the trend within 1 week. The last week when we met, that was the week between the 14th and 20th of June, and compare the changes that have occurred that week to this week. As of today, over the last 1 week, 209 new cases of COVID-19 have been reported across the continent, and this represents a 31% increase from the previous week. The highest proportion of new cases is from Southern Africa, representing 72% of the cases, and the other regions are indicated as follows: North Africa, 16%, East Africa, 8%, Central Africa, and West Africa, 2% both. The following 5 countries are reporting the highest number of new cases since last week: South Africa, 105,000 new cases, Tunisia, 23,000 cases, Zambia, 19,000, Namibia, 11,000, and Uganda, 6,000 new cases. In terms of deaths, between last week and this week, there have been a total of 3,600 new deaths compared to last week's about 3,000. And this represents a remarkable increase of 23% of new deaths over the previous week. When we now look at the trends, the 4 weeks trend, and that is spanning the period between May 31st to June 27, the following observations are made. A total of 29% average increase has been recorded over the last 4 weeks. And the following regions have reported changes as follows: 43% increase in Southern Africa, 38% increase in Central Africa, 15% increase in East Africa, 11% increase in Western Africa, and a 10% decrease in North Africa. In terms of death, over the last 4 weeks, as a continent, we have recorded a 19% average increase in new deaths, with the following breakdown amongst our most populous countries: a 108% increase in the Democratic Republic of Congo, 43% average increase in Kenya, 20% average increase in South Africa. 3 countries have observed a decrease in number of deaths: 18% in Ethiopia, 8% decrease in Egypt, and 5% decrease in Nigeria. In terms of testing, a total of 52 million COVID tests have been conducted across the continent. And over the last week, we observed 1.3 million new COVID tests testing have been done. And this is very encouraging. It represents a 15% increase of the number of new COVID testing, that were conducted last week compared to this week, or this week compared to last week. I beg your pardon. The overall positive rate it remains high, above 10%, with a test per case ratio of 9.6. Again, a ratio of 10 test per case ratio is what we are striving to achieve as a continent. As I indicated last week, we are in the middle of a third wave that is extremely aggressive across several countries. 38% of our member states, or 21 countries, are experiencing a very severe third wave. And 10 of those member states are experiencing an extremely aggressive third wave. 6 countries from last week are added to this list, including Eritrea, Liberia, Mozambique, Rwanda, Sierra Leone, and Zambia. To respond to this, the Africa CDC has started since 2 weeks dispatching swab teams into countries. We have 1 team in Seychelles. Another team just arrived in Zambia this week, and 2 teams are heading out to West Africa in the coming days. And also another team is heading to Namibia to help them in several aspects there to see how we can continue to fight the third wave and bend the curve. So in terms of capacity building, we continue to train vaccinators across the continent, and over 700 infection prevention control primary healthcare administrators or vaccinators have been trained last week. And CDC continues to provide training across the continent in the areas of community engagement, where over 1,300 healthcare workers across the continent last week have been trained by the Africa CDC. Let us now segue to the vaccine situation on our continent. As of June the 28th, the African Union member states have reported the following. 65 million COVID vaccines have been procured by 51 member states. Of that, 49.6 million COVID vaccines have been administered, which represents about 76% of the total supplies in Africa. So I think, again, as I remarked last week, if the vaccines are there, the population will use it. So an uptake of close to 80% is remarkable. The coverage is around 1.07% of the population that has been fully vaccinated if we adjust for numbers that and the variables in Egypt and other member states that have readjusted their numbers downward from the 1.1% last week to 1.07% this week. The good news is that some countries are making very good progress. Morocco, for example, has used all its 18.9 million doses of vaccines and has actually fully immunized 24% of its population. Egypt has used up to about 60% of its vaccines, its 4.3 million vaccines. Nigeria has used up to about 90% of its vaccines. Algeria has used 93% of its vaccines, and South Africa has used about 50% of its vaccines. So again, very encouraging to show that if the vaccines are available, people will continue to use the vaccines and through various campaigns. On June 29, the Beta variant vaccine phase 3 trials began. And this is the first the participation of this variant study to begin to vaccinate and assess the immunogenicity of these the vaccines against the AstraZeneca vaccines that are out there. The trial will recruit about 2,500 participants from the UK, South Africa, and Brazil, and Poland to see the effect of the new variant, that is the Beta variant that is transmitting very aggressively on these vaccines. The Cuban Adela vaccine against COVID-19 has shown an efficacy of 92% at preventing symptomatic COVID cases in stage 3 clinical trials. The vaccine is given in 3 doses at an interval of 2 weeks. Full data from that study remains to be shared. Let me just end by sharing with you this very interesting and remarkable news that the United States International Development Finance Corporation, DFC, has announced a joint financing package of about 600 million euro for the Aspen Pharmaceutical Pharmacare Holding, with headquarters in South Africa to expand local vaccine manufacturing capacity. DFC is working together with DEG from Germany, Propaco from France, and International Finance Corporation to make the financing available. And the aim is to make sure that vaccines are produced and primarily distributed to African Union member states, South African government, and to COVAX. So that represents very good news and remarkable progress in ability to continue to get vaccines to our people. So thank you, Wayne. I will now turn it over to you.
Thank you very much, John, for that briefing on the status of COVID-19, as well as touching there on some issues regarding the vaccine situation. Now, colleagues, as I mentioned before, today we are being joined by Mr. Strive Masiwa. And Mr. Strive Masiwa is the African Union Special Envoy on COVID-19. And he's also the coordinator of the Africa Vaccine Acquisition Task Team, also known as AVAT. So he's joining us today to talk about vaccine acquisition and distribution across the continent. And he's here with us and on standby. Mr. Masiwa, Mangwanani, good morning, and you have the floor.
Thank you very much, Win. Morning, Dr. John, my twin brother. I spent so much time with John, they now believe we're twins. So when I can't go somewhere, John goes. When John can't go somewhere, I go. Good morning, and we meet on clearly a very grave matter. As John pointed out, I am the African Union Special Envoy, assisting, coordinating resources around this crisis. And I've been in this role since at least April last year. Dr. John Kengasong and the Africa CDC in August last year presented to the African Bureau of Presidents that for Africa to be able to ultimately defeat this virus, we needed to vaccinate at least 60% of our population. Based on on how we look at the continent's population, that is roughly 780 million people. The African Bureau of Presidents, chaired by President Ramaphosa at the time, and attended by all the regional, the leaders of the RECs, all agreed that member states should target 60%. And it was consistent very much with the targets set by other other regions around the world. The United States is even higher at some 75%. Europe is 70%. But the scientists at the Africa Center for Disease Control said we should go for 60%. The heads of state then assigned the special envoys to work with the Africa Center for Disease Control to see how these vaccines could be acquired. We knew then that vaccines would become available from about December. And we were then constituted by President Ramaphosa into a special task force known as the Africa Vaccine Acquisition Task Force. And it became, as I've pointed out many times, and I'm not going to relitigate this issue today, it became pretty clear by December that the hope that we would all, as a global community, buy vaccines together through this structure called COVAX was not being adhered to, particularly by the rich and powerful nations. We nevertheless engaged the donor community, sometimes in meetings led by President Ramaphosa himself, to try and establish the level of support that the donor community was willing to provide. And they made it clear at the beginning that they would never go beyond 20% of our population in donor support, which meant that Africa would have to acquire the additional vaccines itself if it wanted to get to 60%. And hence President Ramaphosa then empowered the committee to not only look for vaccines, but to raise money to help member states acquire vaccines. So we initiated, for example, I'm sure you saw the big statements last week from the World Bank. We initiated those talks as far back as November, because we knew that member states did not have the type of budget provisions for this kind of purchase. So we approached the World Bank on behalf of the member states and began to engage them. And as I'll point out later, that has been very successful. What was less successful was just the availability of vaccines. It really doesn't matter what country, how much money your country has. It couldn't buy vaccines. You know, I've sat with presidents who were personally calling. I've never seen presidents try so hard. They were calling manufacturers, chief executives, John knows. And there was no vaccines. There hasn't been vaccines available for 2021. The greatest opportunity for us emerged when we realized that there was a factory in South Africa which could be used to manufacture vaccines. President Ramaphosa then got this company, which John mentioned just now, called Aspen Pharmaceuticals to conclude an agreement with one of the manufacturers called Johnson & Johnson, which was anticipating that its vaccine would become available end of February, March. So we were hoping to use that factory to start the production. So getting back to the numbers, where we are directly as the Africa Vaccine Acquisition Task Force, we have entered into an agreement to purchase 400 million single-dose vaccines, which is enough to cover 400 million people. They are not double-dose vaccines. They are manufactured by the Johnson & Johnson company. In our calculations, we also included the Caribbean countries, the CARICOM countries, because they approached the African Union leadership faced with the same crisis that they could not buy. So the presidents invited the countries of Jamaica, all those regions, Barbados, in fact, 14 of them joined the African Union's AVAT. And they have been purchasing not only vaccines through us, but we share everything that we get with them as well. So we have purchased 400 million doses. All suppliers require purchases be made in advance. There is no other way by which you can get vaccines, which created a big problem for us because we had to first raise the money. The World Bank could only lend to countries once vaccines were available, not before. So Afri-Exim Bank was given the task by the member states to raise this money. Afri-Exim Bank is owned by the member states. Its shareholders include countries like Nigeria, Egypt, Zimbabwe. In fact, the top 10 countries, I must recognize, the top 10 countries, we met with the finance ministers, and they then headed straight to their heads of state and refinanced the balance sheet of Afri-Exim Bank so that it could be able to carry the loan to purchase $2 billion worth of vaccines. Without that, we would be nowhere. So they provided $2 billion of the $3 billion that we needed, allowing us to enter into agreements. So we concluded the agreements at the end of March. Manufacturing is now in progress. According to our supply agreements, the first shipments are due in 1 month's time, in August. And we will have all shipments delivered over a 12-month period. So we are now in the process of training, preparing the member states for the arrival of vaccines. It's been a remarkable response by the member states. They have all literally, as we stand, over 50 member countries have joined and made orders for their share of the 400 million doses. We obviously, as the committee, we are responsible for coordination with the COVAX facility, because the COVAX facility is supposed to deliver the other 50% of the required vaccines. They had advised us in January that they would deliver 700 million doses by December at the rate of 14 million doses a month. You don't need me to tell you that that hasn't happened. To date, less than 50 million doses have arrived. This has created a massive crisis because all our planning had anticipated that by now we would have received 700 million doses already financed by the donor community. But this has not happened. The good news, though, is that the United States government, the new government, has really stepped up. They have provided $4 billion to COVAX, who have now purchased 500 million doses of the Pfizer vaccine. We have been meeting, John and I, almost on a daily basis with the United States government and their officials, working through the details of shipments with the COVAX people. We are in literally daily communication. I finished at 11 p.m. last night. The first guy I see in the morning is John. The last guy I see in the morning is John. We spend our time fighting for vaccines. But the good news is the US shipments, the first US shipments in support of their donations will begin next week. John, we agreed as late as last night, the first shipments, which will go to, I think, about 51 member states. And they do include Johnson & Johnson and Pfizer vaccines, because these are United States vaccine manufacturers. So there is movement. But obviously, as you've heard from John, we've got an extraordinary situation with the third wave. I'm not here to complain or litigate about what has happened in the past. I'm just here to give you the facts. We have struggled to get vaccines because we did not have our own production facilities. It doesn't matter what global structures people constructed. The countries that own manufacturing facilities to produce vaccines put controls. They first of all wanted vaccines for their own populations. And it was the same whether we're talking to the East, to the West, whoever. Look, that is just the way it is, okay? And there are still massive, massive restrictions on the movement of vaccines, exports, as well as the materials that make up vaccines. So the initiative around Aspen, we are grateful that it just so turned out that there is a company in Africa with that capability. But it's not only Aspen. We have the Dakar Institute in Senegal. There is capacity in Egypt, Morocco, Nigeria, which could have been used more effectively over the years. And so one of the failings that we want addressed is the fact that the global purchasing of vaccine, which is done by Gavi, has tended to focus its purchases from India, 94%. Therefore, not create help. They need to turn their attention to using that buying capacity to also support African manufacturing capabilities. Had they been doing that over the years, we may not have found ourselves in such an acute situation. But these are lessons for our leaders in future. A lot of our attention now is to make sure that we have those production facilities in a number of countries. And with those words, I will stop there. Thank you, John, for allowing me to take up so much airtime to come. I hope I have been comprehensive as be. Next time we will have greater brevity from me.
Thank you very much. That was Mr. Strive Masiwa, who is the African Union Special Envoy on COVID-19 and also the coordinator of the African Vaccine Acquisition Task Team, AVAT, giving us a background to the situation of vaccine acquisition and going into manufacturing, as well as the current status of the vaccines that we are expecting to be available to the African continent in the very near future. Thank you very much for that. So colleagues, we have now come to the question and answer section, and you may pose your questions to either of our panelists. either Dr. John or Mr. Strive Masiwa. And the way in which you can do that is to come through on that usual WhatsApp number, which is +251 94 550 2310. +251 94 550 2310. You can also ask your questions live and as well use the question and answer section. All right, let's dive straight in because already we have quite a lot of questions that have come through. And the first one to put up their hand this morning is Gabriele Steinha from the Wall Street Journal. Good morning, Gabriele. Please go ahead with your question.
Good morning. Thanks so much. Two questions actually, but short ones. One is, do you have any data on what variant or variants are driving this terrible outbreak in Zambia? Is it also Delta, or is it still the Beta variant that was dominant there previously? And then do you have an update on the team that you sent to the Seychelles to investigate the efficacy of the vaccines used there? Thank you so much.
Gabriele, I'm assuming your questions are for Dr. John, am I correct?
Correct, yes, thank you.
Dr. John, please go ahead.
Thank you, Gabriele. Our SWAT team just arrived in Zambia this week, and you probably have seen some of my tweeting where they arrived with tons and tons of response material. And one of the requests from the government of Zambia was for us to look into the analysis of the variants there. So as we speak, I can't tell you for sure what variant is driving it because we have not seen the data, but I'm hoping that next week when we meet, I should be able to give you an update of this. So I'll let my media people take note of that question so that we can give you the specifics to that answer next week. Seychelles, the team is concluding tomorrow. We extended their stay there by another week, so they will be concluding tomorrow. So again, let's see what they have to say on the situation. That the detailed analysis will be made available hopefully next week when they are back. But as we speak, they are not back. They are still in the theater of operation.
Thank you very much. We have the next two questions coming from Coletta Wanjohi, who is with FSN. And she says, Dr. Nkengasong, kindly speak on where Africa stands with the recent decision by the European Union not to recognize some vaccines like the AstraZeneca produced by the Serum Institute of India under its digital green pass. Is the Africa CDC going to engage with the EU directly on this? Because most of Africa is depending on these supplies under the WHO COVID shield. And then there is a question for Mr. Masiwa. And Coletta says, as we seek more supply of vaccines, how complicated are such discriminatory policies, such as that of the EU? How difficult are they making to your effort to get more vaccines for the continent? So let's start with the question for Dr. John and move on to Mr. Masiwa.
So thank you, Coletta, for raising that question. And as if you recall, when over the weekend, we started getting news and stories that what was happening in Europe with respect to including some of the vaccines on their Green Pass program. And on Monday, we reacted very swiftly. We issued a statement, both in French and English, which we express clearly our position. The position is simple, that the vaccines, the AstraZeneca vaccines that came from India were funded by COVAX, supplied by COVAX, and COVAX is supported by mainly by the Europeans. Okay, until recently, when the Americans joined, is supported by the Europeans. So that came as a big surprise to us, that a vaccine that has been supported by the Europeans and supported by COVAX, supported by WHO, will not be allowed to be on the list of vaccines that were recognized through the Green Pass process in Europe. We've always said when this pandemic started, that we should always use science, data to drive decisions. And I don't think this is one that was based on science and data, because if you look at the neutralizing antibody levels, which all these vaccines are generating against the spike protein, that the vaccine, that is the AZ vaccine produced in India, produces very high neutralizing antibodies. I think that is what, I mean, if they were producing less quality neutralizing antibodies, you probably argue that based on that, I mean, they are not fit to be recognized. So we are really calling on the European to stay away from such policies that will further undermine and make it difficult for us to fight this pandemic. It is a serious pandemic. The vaccines that most Africans have received on the continent are vaccines that came from the COVAX facility from India. I was personally at the airport together with the head of the European delegation at the AU, receiving the COVAX vaccines from India that fateful morning, very early in the morning at 6 a.m. in the morning. So to turn around and say that they will not recognize that is very troublesome. And we really are hopeful that they will reverse that condition very, very quickly.
Thank you. Let's move on to Mr. Masiwa for his part of the question.
I'll pivot straight from what John is saying. You know, we met with President Macron and the African Union leaders, the Bureau of Presidents, the 10 leaders. And President Macron represented the donors who finance COVAX. They finance COVAX. The vaccines purchased by COVAX are supposed to be their money. So how do we get to a situation where they give money to COVAX, who go to India to purchase vaccines, and then they tell us that those vaccines are not valid? I'm not going to debate that point. It's self-evident where the problem is. But it's not the only problem we have with the EU. And let me address the EU. The fact of the matter is the EU has vaccine factories. It has vaccine production centers across Europe. Not a single dose, not one vial has left a European factory for Africa. Okay, when we've gone to talk to their manufacturers, they tell us that they are completely maxed out, meeting the needs of Europe. We are referred to India, okay, where a number of manufacturers exist that are manufacturing vaccines like the AstraZeneca vaccine under license. Okay, so Europe has to decide. You know, you can't say you support us. They have vaccinated so many of their own people that they can now watch football without masks. Okay, our people have not been vaccinated. Less than 1% of our population has been vaccinated. That is just the facts. Okay, they don't need me to interpret them. Okay, now is the time for Europe to open up its production facilities so that we can buy vaccines. We are not asking for donations. We have money to buy vaccines. Vaccines are not expensive. Certainly not when it comes to the lives of our people. The poorest of the poor African countries have all stepped forward and paid deposits for us to buy vaccines. Okay, but we need those European factories. In the Netherlands, all those, Belgium, Italy, they must open them up and sell vaccines. We didn't ask anyone for a donation. So these are the facts.
Thank you very much. We have a question that's coming from David Wafula of the BBC Africa, but that question has already been taken up by Dr. John, and it was on the issue of the Green Pass. So we move straight on to a question from MacDonald Zirutwe, and MacDonald is with Reuters. And he is addressing his question to Mr. Masiwa, and he says, could you give us the latest? how many African countries have actually confirmed their orders and paid their deposits to Afreximbank for the J&J doses that AVAT secured? And why have countries been slow to confirm their orders and pay their deposits for the J&J doses, which were secured in March and for which African Union has worked so hard? So that's the question from McDonald Zirutwe of Reuters.
McDonald, I don't know where you get this idea that they have been slow. No one has been slow. For purchases, the process that we concluded the contract at the end of March. Countries have to apply. We've given them the opportunity to apply for their doses. We've given them the opportunity to go and get approvals that they need. They have to review the contracts. Each country must sign on to the contracts, the indemnities that are associated with these products. We are perfectly happy with the process. Remember, every country knows the shipment date to be August. Last week, we met with all the finance ministers, all the health ministers, with the World Bank. We have a meeting this afternoon. The processes are going as well as I expected, if not better. So I'm not an unhappy camper about the process, okay? And we have a team ready all the time to answer and to deal with problems. A lot of the countries didn't have the money, which meant they first had to apply to the World Bank for a loan, get the World Bank to process the loan, and then come back to us. The World Bank, as you know, have announced that they have now received requests for loans from 41 countries. And they have promised us that they would process all those loans before the end of June. And that's partly why we're meeting today. So it's well on track.
All right, thank you very much for that assurance. Colleagues, we have a lot of questions that are coming in and we have to go through them in the next 20 or so minutes. So I'm going to be asking my colleagues from the media to please just pose the one priority question that you have. And if we have extra time at the end of it, we will then come back for second follow-up questions. So with that, let's move straight on and back online. And we say good morning to Paul Adepoju. Paul, please go ahead with your one question.
Yeah, thank you very much for taking my question. So I'd like to ask Mr. Strive what the plan for COVID Shield is, considering they've not been able to meet up with the arrangement. So is AVAT completely phasing out the vaccine? And what do you think the guidance for individual persons, Africans that have already received these vaccines and are planning to travel to Europe? So what is the guidance for them should be?
Just by way of clarity, Covishield is the AstraZeneca vaccine produced by the Serum Institute. We met with the Serum Institute in November and December and January as AVAT, and we took the decision not to buy from them. We feel totally vindicated by our decision that they would not be able to deliver. We understand COVAX has an order with them of more than 500 million doses. We have also heard that several countries have made direct purchases from them. None of those have been delivered. The excuse given is that the Indian government has banned exports. When we met with them in February, it was pretty clear that they were not going to be able to ship. And that's why we went back to the member states and we said, despite the very favorable price of this particular vaccine, we would not add it to our own portfolio. So I cannot comment beyond that. The rest has to come from COVAX as to when they might expect more doses to come through, or if ever they'll get doses. I think at some point they will come through. But where we stand right now, I cannot speak for Covishield.
Thank you very much. Let me take a question that has come through on our WhatsApp platform, and it's coming from Gabriel Baglo. And Gabriel is a senior advisor with the Congress of African Journalists. And his question is to Dr. John. He says, my question is on the second jab. Is it appropriate to take another vaccine that is different from the first jab that is no longer available? So for instance, if one took AstraZeneca, can one take J&J or another for the second jab? That's for Dr. John.
No, thank you. That is a question that has been coming up a lot. And the short answer to that is yes, you can do that. The studies are now beginning to show that if you take that, I mean, it also, the vaccines boost your immune system just as if you were taking the similar, the identical dose. So if you took AstraZeneca vaccine today, and you take either Pfizer or Johnson & Johnson, it really produces a very strong reaction, a positive immunological reaction. So yes, you can definitely do that. But ideally would be to stick with the same vaccine, as that was how it was tested in clinical trials before issuing that efficacy that you all heard when the vaccines were being produced, and we were told that the efficacy is either 90% or 95% or 60%. So I think, but with the shortage and the challenges that Strive just mentioned with access to vaccines, studies now conducted in laboratories have shown that laboratories and in clinical trials have shown that you can do that as well. So I think we have always said that for the AstraZeneca situation on the continent, because of the shortage, that once you get the Johnson & Johnson vaccines that you heard Strive mention, that will be arriving beginning the first week of August. Those who have received their AstraZeneca doses and are in short supply of the second dose can always get the second dose, the Johnson & Johnson single shot.
Thank you very much, John. Yes, Mr.
I can even say, John, the good news is that the first shipments of Johnson & Johnson vaccines is next week. But we will be shipping the vaccines jointly with COVAX as donated by the United States government.
Yes.
And they are going to all member states. Obviously, if you're a healthcare worker and you have had only one AstraZeneca vaccine dose at some point earlier, and you've been waiting for your second one, speaking with my diploma given to me by Dr. John, and so much time with, I urge you to take that Johnson & Johnson vaccine as your second dose and move on.
Thank you very much. We go back to questions coming online, and welcome Sophie Mokoena of the South African Broadcasting Corporation. Sophie, please just tell us who your question is directed at, and then go ahead.
I'm sorry to disappoint you. I need to ask questions, one from Dr. Nkengasong. Dr. Nkengasong, the issue of the beta variant on the continent, the challenge in terms of efficacy of vaccines, have you finally come up with a clear answer what member states must do? And then to Dade Strive Masiwa, and Dade Masiwa, you were very critical on COVAX facility. And do you think the COVAX facility, we can put a blame on them for the delay in access to vaccines on the continent, and how they've administered this whole facility?
All right, let's start with Dr. John.
No, thank you. I think, Sophie, so let me address your question this way. One, we know for sure that the current vaccines that we have are working well against the Delta variant. So the Delta variant transmits about 40% more than the usual variants. Of course, it means it causes death and overwhelm your health system. But in terms of vaccines, efficacy there. We have no evidence so far that the vaccines that we are using, be it the Pfizer, the Johnson & Johnson, and others, are less efficacious against that particular variant. We had very clearly the B135 variant from South Africa was problematic against the use of the AstraZeneca vaccine. So far, that is that is the science we know. And that's why we are very confident and really are in urgent need to move the Johnson & Johnson vaccine. That particular vaccine has also been studied across different variants, and it tends to hold its own in terms of producing neutralizing antibodies at sufficient levels. All the vaccines that we have out there, if you challenge them with the B135 variant, they reduce the neutralizing antibody level, but not significantly. That would not give you enough protection. The only vaccine that knocks it down that very significantly, that is from this variant, is the AstraZeneca vaccine there. So that is what we know, that is what science is telling us. What does this mean in terms of the continental approach? It means that we need to analyze the variants more frequently to see the shift. I mean, as one of the colleagues, I think Gabriele